Hello everyone, today I will discuss our responsible AI system for stroke prediction developed for the AMS classification challenge. Our goal is to maximize the classification accuracy while ensuring the fairness, explainability, and ethical decision making. Let's dive into how we achieve this. Well, the first part is about the RAI principles and fairness. To ensure our model to the responsible AI principles, we focused on fairness, transparency, and accountability. First, let's look at the fairness. Our data set, as shown in the figure 1, highly imbalanced with around 12,000 non-stored cases and only 250 stroke cases. This imbalance could lead to the model to favor the majority class, so we use a smart overall sampling with a sampling strategy of 0.08 to balance the training data. And this ensures the model doesn't ignore the minority class. Those with drugs, which is critical in a healthcare context, where missing a stroke case could be life threatening. And next, we assess the fairness using the Fair Learn library, focusing on gender as a sensitive attribute. And the results show a demographic parity difference of 0.35 and equalized out of 0.366, and this low value suggests that our model treats genders fairly, with minimum disparity in prediction rates and error rates across groups. However, even this small difference indicates a potential bias. For example, if one gender is slightly more likely to be predicted as having a stroke, this could lead to unequal medical treatment. And to address this, we could further adjust the model with fairness constraints or revisit samples in future iteration. Transparency will achieved through explanation tools, which I will discuss next, and accountability was ensured by validating our model's performance and analyzing its ethical implications. Well, the second part is about improving the model interpretability. And to make our model interpretable, we use several explainable AI technicals which also support ethical decision making. Let's start with the global explanations. We use the shape to understand um, how our features the model's predictions overall. And the feature 4 shows the shape summary plot, where age had the highest impact, and the higher age increased the likelihood of predicting a stroke. And features like the average glucose level and smoking status also play a significant role. This aligns with the light GBM features importance plot in Figure 5, where glucose, BMI ratio, and age are the top contributors. This global insight help us understand what drives the model decisions occurs all the predictions and ensuring the transparency. For local explanations, we use Lime to explain the individual predictions, and the figure 6 shows the Lime explanation for the simple predict to have a stroke with a 90% probability. And the Lime highlights that a high glucose BMI score of 0.05 and an age of 79 strongly contribute to this prediction, while the absence of the hypertension slightly reduces the likelihood. And this local insight is crucial it is crucial in healthcare as it allows the doctors to understand what a specific patient was flagged as a high risk and enabling the informed and ethical decision making. Well, we also visualize the data and the model behavior to enhance interpretability. And the figure 2 shows the TSNE plot mapping the high-dimensional data into 2D space, and where there is some separation between the stroke and non-stroke cases. The overlap indicates the challenge of uh, distinguishing these classes, and the figures 3, the decision boundary plot after the PCA reduction, shows how the model separates the classes in a simplified 2D space. Finally, the confusion matrix in figure 4 revolves 1000 one removes 1673 true negatives and 95 true positive, but also 374 false positive, indicating the model over predicts strokes a point will revisit in the ethical analysis. This method supports the ethical decision making by providing clear, actionable insights. For example, knowing that the age heavily influencing the predictions allow us to scrutinize whether this reliance might lead to agilism, ensuring will address such bias proactively. Let's discuss the ethical implications about our model. The reliance at the age as a top feature, as say in figure 4 and 5, raise concerns about the um, age ageism, and older patients may be like flagged as high risk, which could lead to unnecessary medical interventions or distress. Conversely, the confusion matrix in figure 4 shows 674 face positive patients predicted to have a stroke who don't. And in a healthcare setting, this could cause anxiety or lead to costly unnecessary tests. And on the other hand, missing the true positives could delay the critical care. Though our model only has six phase negative, which is a positive outcome. The fairness matrix stores slight gender bias, which could result in unequal treatment. Ethically, we must ensure that no group is unfairly targeted for medical intervention based on the bias predictions. And to mitigate these issues, we could incorporate the fairness aware algorithms or involve the domain expert to refine the feature selection, reducing the risk of amplifying the social bias present in the data. Well, in summary, our straw prediction model to the a RAI principles through the fairness assessment, explainability with shape and line, and all ethical analysis. Well, the model performs reasonably with a F1 score of 0.3046. This room for the improvement in reducing the phase positives and addressing the potential bias. And these steps ensure our model support and ethical, transparent, and equitable decision making in healthcare. Well, that's all for our project. Thanks for watching.